We at the Hamilton Centre recognise the Wurundjeri people of the Kulin Nation as the traditional owners of the unceded land on which this webinar is recorded, and we extend that respect to Elders past and present. At the Hamilton Centre, we acknowledge all Aboriginal and Torres Strait Islander peoples and their rich history of care and connection to the land, sky and waterways. My name is Annie Williams and I am the Relationship and Partnership Lead for Hamilton Centre. On behalf of the Hamilton Centre, I would like to welcome you all to this webinar, Effective Opioid Pharmacotherapy for Co-occurring Mental Health and Substance Use Concerns, and introduce my colleague and our expert presenter, Alice Frank. Alice is the Senior Clinical Pharmacist at Hamilton Centre and brings her expertise in mental health and substance use disorders to this presentation. Alice has extensive experience in clinical and leadership roles within the Victorian Public Health Service and is passionate about the positive impact mental health pharmacists have in ensuring patient-centred and evidence-based treatment. Alice's presentation focuses on the Victorian perspective of community-based and primary care-based prescribing. At the end of the presentation, Alice will be here with me to answer questions. Please feel free to place your questions in the Q&A function at the bottom of your screen, and I will be collating them during the presentation. Here at the Hamilton Centre, we recognise the lived and living experience workforce and all people accessing our services as their expertise and partnerships and experiences help us shape services that are safe, accessible and inclusive.
Thank you, Annie, and hello, everyone. Today I will be talking about bridging the gap and how we can provide effective opioid pharmacotherapy for people experiencing co-occurring mental health and substance use concerns. I would also like to take this opportunity to acknowledge the work of Dr. Catherine Oliver and Dr. Ali Cheetham, who contributed to the Hamilton Centre opioid pharmacotherapy module, and a lot of the content for this presentation is derived from that as well. So today I will be going over, firstly, what opioid pharmacotherapy is and its role in treatment of opioid use disorder. I will be focusing on the Victorian treatment settings, including some of the insights that we've gained from the Hamilton Centre Opioid Pharmacotherapy Survey, and also looking at the role of SafeScript in supporting clinical decision-making. I'll then be looking at some of the key considerations for providing integrated management, including some drug interactions with mental health medications and opioid pharmacotherapy, and also talking about some effective strategies that can be used to support people that are living with opioid use disorder as well. So opioid pharmacotherapy is the use of medication to eliminate opioid withdrawal symptoms, control cravings, and block the effect of further opioid use. It's important to recognise that people can receive opioid pharmacotherapy for a range of opioid use disorders, including dependence on both illegal opioids such as heroin and also pharmaceutical opioids such as oxycodone or codeine. In 2022, the proportion of people that were receiving opioid pharmacotherapy for the use of pharmaceutical opioids, as reported by the Australian Institute for Health and Welfare, was reported to be 26% of people. There are a range of other terms that can be used for opioid pharmacotherapy, and some of these might be familiar to you. These include opioid agonist treatment, or OAT, MATOD, which is medication-assisted treatment for opioid dependence, ORT, which is opioid replacement therapy, or OST, which is opioid substitution therapy. So we recommend that the use of the terms opioid pharmacotherapy or opioid agonist treatment are the preferred terms that should be used when talking about opioid pharmacotherapy, because these terms are more precise and they're much less open to interpretation, and more importantly, they're less stigmatizing than other terms like replacement or substitution. So why is the use of words important? Let's take a look at some of the headlines and depictions of opioid use disorder and pharmacotherapy in the media. So we have this stigmatizing and very negative language that's frequently reported, and that's ranging from people accessing treatment, around the impact on our hospital system, people that are being captured that have overdosed in public, the negative stigma that was associated with the injecting room, and also the recent changes that occurred last year in the transition to pharmacotherapy being accessible on the PBS. So it's really important for providers and clinicians to be aware of this stigma that's portrayed in our media and the impact that this will have on people in terms of their willingness to engage in treatment or discuss their opioid use concerns as well. The aim of opioid pharmacotherapy is to help people that are dependent on opioids, so whether that's illegal or pharmaceutical opioids, either reduce or stop using these opioids. We want to improve people's physical and psychosocial health and their functioning in their day-to-day lives as well. And we also want to reduce the risks and harms that are associated with both illicit and unsanctioned opioid use for the individual themselves, for their family, and also their wider social network as well. Because we understand that the impact of opioid use has a wide-ranging impact on social functioning, relationships, ability to maintain employment as well. So what are some of the benefits of opioid pharmacotherapy? So it's been demonstrated in some recent systematic reviews that the risk of overdose death was 8.1 times lower for people that were receiving opioid pharmacotherapy. And this is compared to people that were not receiving treatment at the same time. There was also a further benefit of a reduction of 5 to 13% of mortality risk for each additional year that someone remained in treatment. There has also been demonstrated a significant reduction in all-cause mortality, so not just associated with overdose, so associated with physical health, mental health as well, for people that have been receiving opioid pharmacotherapy as compared with periods of time when they were not receiving treatment. There are also other benefits apart from lowering the risk of death. So there's also a general improvement in people's physical health, so particularly conditions like cardiac conditions, respiratory conditions, and just their general health and well-being as well. There's also a reduction in illicit opioid use and a corresponding reduction in the transmission of blood-borne viruses such as HIV and hepatitis. It's also been demonstrated to reduce drug-related crime as well. And importantly, there's been a general improvement in people's overall mental health. And this is independent of whether someone is receiving either psychosocial or medication treatment for their mental health. So the mere impact of someone having opioid pharmacotherapy has a corresponding benefit on their mental health as well. So each year, the Pennington Institute produces the annual overdose report, and the report for 2022 was recently released in August this year. So as you can see here from this graph, the number of unintentional drug-induced deaths for 2022, the opioid-associated deaths was significantly higher than any other medication or substance that was monitored. So opioids accounted for almost 50% of these unintentional deaths. And it's also important to recognise that the proportion of unintentional drug-induced deaths accounts for 80% of deaths. So it's a significant proportion as well. Opioids are also commonly indicated in deaths that are associated with polydrugs or multiple substances in the one death occurrence, and account for up to 80% of those presentations as well. In terms of the age of people that were taking opioids and experienced an unintentional death, their cohort is actually people aged 40 years and over that are most likely to experience a drug-induced unintentional death that involves opioids as well. And the other thing that was reported, so there's also a difference between males and females. So males are more likely to have a death that involves heroin, which was involved in approximately 50% of these deaths. But in females, the proportion is much higher for pharmaceutical opioids. So this was accounted for 60% of the unintentional drug-induced deaths. So looking at the breakdown of opioids specifically, we can see a general increase in the deaths that have been associated with heroin, which is indicated by this dark blue line at the top of the graph here. And then this lighter blue line is the pharmaceutical opioids, including oxycodone, morphine, and codeine. So we can see a general reduction in the deaths associated with pharmaceutical opioids from around about 2018. And this may be a result of the introduction of some supply-side interventions, such as the introduction of real-time prescription monitoring with SafeScript, for instance, the implementation of analgesic stewardship in hospital settings, and also the reformulation of some of the pharmaceutical opioids, including OxyContin. Looking at Victoria specifically and the number of heroin associated unintentional deaths. So Victoria is indicated by this yellow line up the top, and we can see the significant impact of heroin use in our state. And we have by far the largest number of heroin associated unintentional deaths in the country as well. So what medications are used for opioid pharmacotherapy? So we have methadone, which is available in a liquid formulation. We also have sublingual buprenorphine available as the single ingredient Subutex, and also Suboxone, which has the combination of both buprenorphine and naloxone. We also have the long-acting injectable buprenorphine, which has been available in Australia from around about 2019, 2020. And this comes in a range of formulations that are available in either a weekly or monthly injection. So the Sublocade injection is available in a monthly formulation, whereas Buvidal comes with some more flexible dosing, allowing for weekly and monthly dosing as well. So the Victorian context. In Victoria, pharmacotherapy is primarily provided in the community and primary care settings. So between 2022 to 23, 98% of Victorian dosing sites were in pharmacies, and this compares with around about 85% nationally. It requires a permit to be applied for prior to initiation of treatment, and this application of the permit is limited to prescribers that have completed training, and pharmacists that supply pharmacotherapy also need to complete training as well. Prescribers also need to notify the Medicines and Poisons Regulation Unit that they believe that the individual is a drug-dependent person. So as opposed to this being seen as a stigmatizing thing, this is actually to help streamline the individual's care, and also to highlight the need for intervention if other high-risk medications such as other opioids or benzodiazepines are currently prescribed by another prescriber. SafeScript is Victoria's real-time prescription monitoring database for high-risk medicines. So these high-risk medicines include opioids, so including opioid pharmacotherapy, but also other medications such as oxycodone, morphine, fentanyl. It also includes benzodiazepines such as diazepam, quetiapine, and also the recent addition of the gabapentinoids, including pregabalin and gabapentin as well. From April 2020, it was mandatory for prescribers and pharmacists to check SafeScript prior to the prescribing or dispensing of one of these high-risk monitored medications. And you will note that asterisk there that hospital-based prescribers are still currently exempt from this mandate. What SafeScript does is it allows for safer clinical decisions to be made, and also allows for an early identification of any risky medication usage trends that might be emerging. Through SafeScript, prescribers can apply for and also revoke an opioid pharmacotherapy permit if they're no longer engaged in the person's treatment. And all this can now occur through SafeScript. Previously, it was a separate application process. So I wanted to show people what SafeScript actually looks like, because I'm aware that a number of people in the audience might have never seen SafeScript. So what you'll see here is what it will look like if you bring up an individual patient's profile. And what we'll have here is a list of the medications that someone has received. And I will also highlight that this is a test patient and doesn't reflect anyone's actual medication prescribing. And also if the Department of Health has received any notifications from any prescribers. So that would include the drug dependent person notification and other notifications that are available to prescribers, which includes, as indicated here, a history of forging prescriptions as well. So SafeScript also has an alert system, and this works on a traffic light system. So red, amber, and green. So red being the high risk alert. So I wanted to show what some of these high risk alerts look like. So the first one I've listed here is for someone that's been accessing multiple prescribers within the last 90 days. So this is really to highlight that this should be looked into whether some more coordination around treatment needs to be implemented. It's also important to note that this is on the individual prescriber. So if someone sees different prescribers in the one clinic, where people would have access to the same history notes, for instance, this needs to take into consideration as well. There's also an alert for people receiving high dose opioids. So if someone is receiving opioids that exceed 100 milligrams of morphine equivalents, this also triggers a high risk as well. If people have an opioid dose equivalence that exceeds 50 milligrams of morphine equivalents, this triggers an amber alert. So again, trying to implement some clinical decision making and trying to reduce that risk of harm associated with the opioid use. The other alert that appears is the interactions with methadone specifically in pharmacotherapy. So the one that does commonly alert is if people are receiving both benzodiazepines and methadone as well. So this has been acknowledged to be a significant risk of opioid overdose and also respiratory depression, which can then lead on to death as well. So this also is implemented in that system too. I'm now going to move on to talking about some of our pharmacotherapy survey highlights. So earlier this year, the Hamilton Centre conducted an online anonymous survey of clinicians and staff members working in the Victorian area mental health and wellbeing services. And we were aiming to document the current workforce practices for the provision of opioid pharmacotherapy. We received 132 responses, and from that, 103 of these were from eligible services and also sufficiently complete for analysis. We had a high proportion of metropolitan services represented in our sample, and also a reasonable mix of different professional roles. So we had a significant portion of both medical officers and also nurses, and followed closely by pharmacists as well. We also had representation from management and other case management and allied health roles as well. In terms of the services that were represented in the survey, we had, again, a mix of different services, including inpatient and outpatient services, and also community residential services such as PARC or CCU services, and then a small proportion of emergency CAT and crisis services as well. Overall, the respondents to our survey had a significant amount of experience of working in the mental health sector. So we had almost 50% of our respondents had more than 10 years experience. So we could trust that the people had a good understanding of their mental health system. And of those, around about 60% had previous experience with providing OAT. So that could have been in the form of prescribing, dispensing, administering the medication, and also things like supporting a client who was receiving pharmacotherapy, conducting assessments, and those types of things. Of our respondents, 72% reported that they had access to a prescriber in their service for pharmacotherapy, and this was probably higher than we were actually expecting to see in our survey sample. We then asked questions about the number of clients that were currently accessing pharmacotherapy that were engaged in their service. And I will also note that we saw a significant reduction in the response rate to this question. So this might indicate that people might not know that, have detailed understanding of that knowledge, or otherwise not have access to the information at the time of the survey. So we saw a high proportion that reported that no clients were receiving pharmacotherapy, and ranging up to as high as 40%. So again, quite a wide range, and that's probably reflective of the different types of services that were represented in the sample. We then asked a question about clients' preferences and whether people felt that people would prefer to access pharmacotherapy from their mental health team as opposed to having to go to a separate prescriber for their pharmacotherapy and a separate service for their mental health needs. And we, again, saw a really wide range of responses to this question, and again, had quite a low response rate. So this could very well indicate that it might be a question that people need to raise with their clients to understand their preferences for treatment as well. The survey also followed a case scenario, which had an individual who was taking pharmacotherapy through their journey through an inpatient admission via an emergency department, right through to discharge to a community mental health team. And through this case, we were trying to identify barriers to accessing treatment. And there were some different barriers that were raised between the inpatient setting and also in the community setting as well. So of the respondents working in inpatient setting, 47% of these identified barriers, including access to specialist prescribers, lack of training, knowledge, or experience in terms of providing pharmacotherapy. Some of the issues in terms of confirming current doses with community providers, particularly if this was in an after-hours situation or on a weekend, for instance. There was also delays in accessing medication from the pharmacy, and also stigma associated with staff not necessarily identifying the need of someone to access their pharmacotherapy and the impact this might have on their hospital admission as well. In the community setting, 40% of people identified barriers to provision of pharmacotherapy, and this included not being able to access prescribers or the service not being offered at their mental health team. Also a lack of general AOD support in their mental health service, and a lack of easily identifiable referral pathways as well. Again, training, knowledge and experience were identified as barriers, as well as medication storage and legal compliance in this aspect as well. And people also identified the need for individuals to pay a pharmacy co-payment to access the medication as an additional barrier as well. So what does integrated care look like for someone that's prescribed opioid pharmacotherapy? So the same principles in terms of providing integrated care apply for opioid pharmacotherapy and opioid use disorder as well. So it really needs to focus on providing holistic care for an individual. And so pharmacotherapy needs to be provided as part of a comprehensive, holistic view of the individual's needs, including medical care, and as well as social and psychosocial supports as well. And it really does need to be individualized for each person that's accessing treatment as well. Shared decision-making should also be forefront of making any decisions about treatment or support, and understanding the individual's views on treatment and whether they're looking at reducing their use or if they're trying to approach abstinence as well. The therapeutic alliance between services and the individual is also important. So building trust, reducing that stigma that people experience, and also helping people to build engagement with the service as well is crucial. Also, people with specific treatment needs or from other groups that might have differing needs in their services, so such as First Nations people or younger or older people as well, also need to be considered and try to address these unique needs that people might have as well.
Yep.
It's been shown that integrated AOD and mental health treatment for people that are receiving pharmacotherapy is associated with better psychiatric outcomes compared to people that need to access treatment in parallel. So accessing pharmacotherapy from one provider and then mental health support from another provider as well. And some of these outcomes include remaining in treatment for a longer period of time, attending their appointments more regularly, and also importantly experiencing a greater reduction in their psychiatric symptoms and distress associated with these. In contrast to this, people who have been referred from their mental health service to a different AOD service, for instance, may have high levels of treatment commencement rates, but then ultimately lower rates of retention and attendance at these appointments from both services as well. It's also important to consider the impact of trauma in this client group. So people that receive opioid pharmacotherapy have an estimated PTSD prevalence that's 10 times higher than the general population. So this has significant impact on treatment outcomes and accessibility to services as well. And this really does highlight the importance of providing trauma-informed care for these individuals. So that really focuses on creating an environment that's safe for the person to access and building that level of trust both in the individuals and the service more widely as well. Really also highlights the importance of peer support if it's available to help people engage in services and having that non-clinical environment and person to, raise concerns and to help build their goals and relationships as well. The importance of collaboration with the individual to engage in their treatment and also their needs and wants from treatment and from the service as well, and giving them empowerment in terms of what that might look like for them as well. Again, cultural responsiveness is crucial, and ensuring that our services are safe from that perspective is also essential. So looking at drug interactions for mental health medications. So I won't be going into a lot of detailed pharmacology in this section because I understand our audience has a wide range of experiences and needs in this area. But there are a number of resources that people can access if you do want to read further information on this. Broadly speaking, there are two key types of interactions with medications. So firstly, there is what we call pharmacokinetic interactions. So these result in a change in the way that a medication or substance is absorbed, distributed in the body, metabolized or broken down by the body, and then ultimately excreted or removed from the body. So often these will involve competition between two substances or medications for the liver enzymes that metabolize and break down medications. And these are called the cytochrome P450 enzymes. And it's important to recognize that methadone uses some of the more common enzymes that are used to also metabolize and process other medications. So these enzymes are the CYP1A2, 2D6, and 3A4. So you don't really need to remember those names as such, but just recognize that they're probably the three most common that are involved in breaking down other medications. So as an example of this, if you have someone that is on methadone and also taking the antidepressant fluvoxamine, both of these medications rely on the CYP2D6 enzyme. And so what happens in this situation is when those two medications are taken concurrently, the fluvoxamine inhibits or blocks the effect of that enzyme, which then results in an increase in methadone concentration and also side effects. And the most important side effects I'm talking about are sedation and respiratory depression. And respiratory depression refers to a slowing down of the breathing rate to a point that can ultimately lead on to death as well if it's not detected early enough. Conversely, if someone stops taking fluvoxamine, this inhibition of this enzyme here is removed, and the person may then experience opiate withdrawal symptoms due to a drop in the methadone concentration in the bloodstream as well. The other sort of interaction that can occur is a pharmacodynamic interaction. So this occurs when two or more medications have the same or opposite physiological effect in the body. So in this case, sedation, for instance, and this can either cause an additive effect or an antagonistic effect where it opposes that effect in the body. So again, an example of this would be the combination of methadone and diazepam, which is a particularly risky combination because they both cause a sedating effect. And so this amplifies that sedation effect and ultimately respiratory depression as well. So the most significant interactions result in that additive respiratory depression and sedation risk. So this can increase the risk of overdose and also death as well. The medications that are commonly implicated in this are the benzodiazepines that I just explained before with diazepam, and also other sedative medications that might be used for sleep, such as zopiclone or zolpidem, for instance. Antipsychotics also have significant sedation risks, and this is a particularly high risk for clozapine, olanzapine, and chlorpromazine, which have a higher level of sedation associated with them, and also the sedating antidepressants such as mirtazapine and the tricyclic antidepressants such as amitriptyline.
Yeah.
It's also important to note that methadone has a much more significant effect on respiratory depression than buprenorphine does. And one of the reasons for this is that buprenorphine has what we call a ceiling effect. So there's a max limit at the point that it causes respiratory depression, and doses above this level or concentrations above that level don't cause any extra level of respiratory depression. So for that reason, if people are taking multiple medications, have physical health concerns that might predispose them to having, breathing issues, for instance, methadone may not be a good choice for them because of this risk of interactions with other medications, and buprenorphine might be a more preferred option from that point of view. The other important consideration is this effect called QTC prolongation. So QTC prolongation increases the risk of cardiovascular complications, including an abnormal heart rhythm and also the risk of sudden death. So for anyone that's not familiar, the QT interval is something that's measured when someone has an ECG tracing taken of their heart. And so for a normal interval, so this period from Q to T here, is the time that it takes for the heart to both contract and then relax again. So then if it's a situation where this interval is prolonged, meaning that it takes a longer time for this to occur, that's when the complications can arrive as well. The C in the QTC prolongation stands for corrected. So corrected meaning that it is affected by someone's heart rate, and this allows for comparisons to occur at different heart rates. Why is this significant? Methadone in itself can cause QTC prolongation to occur, as well as a range of other medications can also contribute to this. In terms of mental health medications, these include the antidepressants, escitalopram, citalopram, fluoxetine, and again, the tricyclic antidepressants, and antipsychotics. It's potential that all antipsychotics could, but there are some that are higher risk, including amisulpride, haloperidol, and ziprasidone. So the key points to think about in terms of drug interactions: prescribers and pharmacists really need to be aware of all of the current medications and also substances that an individual is taking prior to commencing treatment with opioid pharmacotherapy, and also if any new medications are commenced during treatment. There's significant genetic variability and individuality, so not everyone will experience the same effect. And some interacting medications can be continued if there's extra monitoring or dose modifications that are implemented. Other support services that are available for people to access. So in Victoria, we have the Pharmacotherapy Area-Based Networks, or PABNs, that provide pharmacotherapy support for primary care practitioners. and they aim to connect providers to create a more cohesive system in Victoria. There's also the specialist pharmacotherapy services where people with complex needs, whether that's physical comorbidities that might make their treatment complex, mental health needs, for instance, they can be referred for assessment and commencement of treatment with pharmacotherapy. The ultimate aim of these services is then to have a prescriber that will take on that continued prescribing once they've been stabilised as well. We also have Harm Reduction Victoria, which runs the Pharmacotherapy Advocacy Service, PAMS. And so they can provide advice on harm reduction strategies and also that support and advocacy for clients, particularly those that have had difficulty accessing services or perhaps have been banned from a particular prescriber or pharmacy for a range of reasons. We have the Hamilton Centre that can provide shared care support if you work in a service that's able to make a referral. And also for any clinician working in Victoria, we have the advice and mentorship line available on our 1-800 number, and also a range of education and training opportunities on our website. For acute advice in a crisis type situation or perhaps a hospital emergency type situation, there is also DACAS, which has 24-hour access to an addiction specialist that can provide advice. We also have Direct Line that can provide access to counselling services, a range of resources, and also helping people to link in with pharmacies and prescribers in their area. These are my references if anyone would like to consult them for further reading. And we would welcome further engagement from any of you via our website, via our social media sources as well. Thank you.
Thank you very much, Alice, for such a comprehensive and interesting presentation. And I'd really like to thank our audience too for being part of this presentation. We'll move to questions shortly, so I'd invite people to pop their questions into the Q&A function at the bottom of the screen. Questions or comments, we're very happy to respond. And in the meantime, while you're doing that, and if you wanted to learn more about the opioid pharmacotherapy, please be aware that if you visit the website, there is a range of modules available for individuals. In particular, there is the opioid pharmacotherapy module. We also have podcasts, which you're welcome to listen to, and we also now have some scholarships available to mental health and AOD workers for the grad cert of addictive behaviours through Monash University. This is a very exciting opportunity. There's a limited number of scholarships, so I'd invite you to join or to have a look at the website. The other piece of information I'd like to share with you is that there are some upcoming workshops. Again, that information will be available on the website. So, Alice, if we just move to questions, I have a question, please, around the PBS changes. And I'm just interested on your thoughts about how stigmatising was the cost of treatment prior to these changes.
Thanks, Annie. It's a great question and something that was a real significant change in terms of treatment access that occurred. And it only occurred in halfway through last year. So that change to the PBS is a really recent change. So prior to this, people that were on opioid pharmacotherapy usually had to pay a daily access fee. So that could have ranged anywhere from sort of $5 to $10 per day. So if you compare that to the cost of a medication subsidised by the PBS, which if someone was on a concession card, that's usually around about $7 or $8 a month. So the disparity in those costs is huge. And the other thing to think about is the view of that. So the pharmacotherapy medication wouldn't have counted towards things like their PBS safety net for the year, so they wouldn't have been entitled to those benefits that people access once they've paid a certain amount of medication for their year. So there was a lot of disadvantages to people in terms of accessing the pharmacotherapy, and that in itself is very stigmatizing.
Yeah, it's multi-level. I didn't realize that it didn't contribute to safety net, for example. And if you're thinking about people on limited income with other social vulnerabilities, that's a very significant gap there.
Yeah, definitely. And I guess the other way to look at it, if you compare it to, say, other medications that are subsidized on the PBS, so let's say, for instance, insulin, which is essentially a replacement medication as well, but it's called basis. We don't
Mm.
expect someone that's requiring insulin to pay that sort of same level of fee for medication that they need.
No, that's a really relevant point. Could I bring your attention to SafeScript? I'm just got a query about why are hospital prescribers exempt from this?
That is an excellent question. Thank you for that one. So with SafeScript, the main reason why hospital prescribers are exempt is because we don't have the technologies in place yet to incorporate the electronic medical records that are in place in hospitals, integrating with SafeScript. Whereas in the community setting, the prescribing software that's available fully integrates with SafeScript. So it's for this reason that hospital prescribers are exempt. Having said that, I'll also note that hospital pharmacists are not exempt. So there's a disparity there as well. But that's the main reason. But it should still be encouraged because of the valuable clinical information that can be accessed by hospital prescribers as well.
So could you just remind us who can check SafeScript?
So the people that can access SafeScript with an individual login are doctors, so medical prescribers, nurse practitioners that prescribe medications, and also pharmacists as well.
And this should be done before prescribing any new medications.
Yes, so either prescribing or dispensing in the case of pharmacists as well.
And if you had concerns around a doctor's prescribing or a pharmacist dispensing, can you actually can they be stopped from prescribing or dispensing through SafeScript?
No, so SafeScript doesn't actually stop someone from prescribing or supplying a medication. You can't ban someone from being prescribed, say, more benzodiazepines, for instance. But you do have those alerts in place that I talked about. So it really is a clinical decision-making tool. It's not a punitive or a banning tool for people to use. So there's actually no way to actually stop someone from prescribing or supplying. But it's meant to help that decision-making process about whether it's clinically appropriate or not.
Fantastic. Thanks, Alice. I've got a question from Belinda, who thanks you for the presentation. Belinda's wondering how many of the consumers that were receiving benefits from the co-prescribing of OAT and mental health medications were also being treated under the Mental Health Act?
Okay. I'm taking this as in regard to the pharmacotherapy survey through the Hamilton Centre. And thank you for the question about it, Belinda. Unfortunately, we didn't actually capture that information in that survey. And what the survey really identified is there's a whole lot more information that we could really gain benefit from getting a better understanding from. So it was really asking for clinicians' opinions, understandings, and views. And it didn't go into that kind of detailed information requests, but it's certainly something that we could look at in future studies.
Donna has popped a question in, which I think could also be more of a comment around working with clients with complex mental health and addiction issues, and SafeScript allowing that detail for practitioners to see that the clients are moving around, whether that creates a sense of stigma and a barrier to care because the prescribers may assume that the individual's doctor shopping when in fact they may be just trying to find the right GP for them or one, for example, that bulk bills.
I think that's a really great point as well, Annie. So again, this should facilitate a discussion rather than leading to an assumption about an individual. You might have had someone that's perhaps been in a crisis situation or a family violence situation where they've had to suddenly move to a different area, or as you said, trying to find the right prescriber that fits with their needs and their goals as well. So it is important to not make those assumptions, but to take that information and considering the context of the person that's there with you at that time and have that conversation as well. Of that conversation could be something like, "Oh, I can see here on SafeScript that you've been to a few different prescribers lately. Can you tell me more about what's going on for you at the moment? And having those discussions as well to make sure that there's not anything else going on for the person.
And in a language that's inclusive and not judgmental.
Absolutely.
Yeah, yeah. There's a query here. If a client was using benzodiazepine, being prescribed benzodiazepines and methadone, then on top of that had daily alcohol and cannabis use, would PAMS be the correct service to get in touch with, or would there be another service or a pathway?
So I guess it depends on the need of the person. So PAMS is really a great advocacy service. So if people are having difficulties, say, accessing their pharmacotherapy dosing, but that might not be what that person actually needs. So it might be something more. It might be a harm reduction Victoria. They might need some peer support, perhaps. If they were in an eligible referral service, you could refer to the Hamilton Centre for extra support for that as well. So, while I can't give a definite answer on that one, there's a range of services out there, and it's really important to think that and acknowledge that there are a wide range of resources that people can access as well.
And I guess also the advice and mentorship line with the Hamilton Centre would be a good source of information for some service navigation options for such a complex client. Michael's asked the best source to locate the statistics and information about the QTC prolongation associated with antipsychotics.
There's a range of sources that you can consult on that, and there's information that in the pharmacotherapy guidelines for Victoria that has some detailed information. That there's links to that in our pharmacotherapy module, the Hamilton Centre as well. But otherwise, if you have a trusted pharmacist that you've got a good relationship with, they can also put you into some other useful resources too.
Thanks, Alice. I've just got a question about the survey. What was the biggest learning for you from this survey?
I think what it really showed was that we need to know a lot more about how the pharmacotherapy is provided in our mental health services, the wide range in responses in terms of, even how many people were being currently prescribed and taking opioid pharmacotherapy to people's preferences. We don't really know what people want from their treatment, so it would be really great to get some more information, to talk to individuals that are actually in this situation, that are currently prescribed therapy, to find out, what this treatment's like for them. Would they rather access that treatment from their mental health service? And separate to that as well, I think it also really highlighted the importance of further education and training, which again is something that we're working on developing further in the Hamilton Centre as well.
And I guess, accessing the modules on the website would be a good place to start for individuals who perhaps are not interested in more formal studies, to see whether that is suitable for them. I just also wanted to ask you around the role of integrated care and prescribing and accessing treatment preferences. Why is this so important?
I think it's so important because what we do want to provide is holistic care, and we really need to recognise the challenges in forcing someone to, go to their mental health service, go to their AOD service or their pharmacotherapy prescriber, go to their GP, and to access all these different needs that they have. And, I've talked about trauma in my presentation, the trauma of having to re-explain what their situation is, what's going on for them. If we can try and integrate that as best as we can, recognizing that there's, still some system barriers in place, but in the setting where there's not the option of providing that all in one service, having those communication processes in place that can really help to support the goal of integrated care, to help that be a more holistic and a better experience for the individual, which is what we should really be focusing on.
Yes, thank you. Belinda's just put in the chat, it would be great to see area mental health and wellbeing services accept the co-occurring issues, and also highlights the need for qualified staff, including peer support workers, to to provide this holistic service. And you're quite right, Belinda, and that's certainly something that our service is working towards around capacity building for those particular services.
Yeah, definitely. And also to highlight, and in some of our clinical networks, and again, we're building that as well, Annie, but in services that don't have access to peer support, that some of our clinical networks do have that as an option to provide as one of the services that we can offer as well. So certainly from the Eastern Health clinical team, that's something that's been really valuable and sought after.
Claire's raised an interesting question. Are the barriers of communication, I'm not sure, Claire, if it's barriers of communication services heading towards a MARAM-like based system? I'm not sure what you
I wonder if that's around, I guess the MARAM system, has that sort of level of shared understanding and to your point, which we don't have. And I think one of the challenges we have in Victoria is our health systems are so fragmented. We don't have one, universal health service, for instance. So all of our communication networks and processes are all still very separate. So it's definitely a huge barrier. And I think anything that we can do to help reduce those barriers would be great.
Thank you. I'd like to thank you all again for attending and for your questions. I want to let you know that this recording will be available on our website. So please feel free to share widely. There's more information available on the website. I would also encourage you to get in contact with the 1-800 number if you have any queries that have come from this presentation. Our door is always open. Thank you.